Alright, good day ladies and gentlemen. Now look at this particular result here. This is a typical result of hypothalamic-pituitary neuralgias. The question says, below is the HPG laboratory results of perimenopausal women. When we say perimenopausal, it simply means women that are encroaching or approaching menopause. So these are examples from the age of 35 down to the age of 45. They are actually perimenopausal. Menopause actually enters menopause properly at the age of 50. So within that transition from 35 and above down to 45, you see that the woman is in the perimenopausal time. They have not entered menopause. Their body is preparing to get into that stage. So, but at that point, they can still conceive. They are still fertile. So they say that the test is negative for pregnancy, but presented with 5 months amenorrhea. This person has not entered menopause, but is now experiencing amenorrhea. A 35-year-old woman who is experiencing amenorrhea is not supposed to say no, she's not pregnant. Amenorrhea simply means that the menstrual cycle has been affected. So we are looking at it and say they do the possible dysfunctional gland within the HPG axis using the laboratory test results. So this is the laboratory test results that have been done in order to help you to assess the problem here. So this result is meant to help you know whether the cause of this amenorrhea is it from the hypothalamus, is it from the pituitary, anterior pituitary, or is it from the gonads itself, that is the sex cells, the ovary. So this is a case of a woman, so in this case we're talking of ovary. So looking at it now, there are 3 different patients that present with this kind of condition. So let's look at the first patient result. These are the ones that are acid. See FSH, that's the follicle stimulating hormone. It is higher than the normal. So this all means high, increased than normal. This LH also is increasing, higher than normal, the normal range. And then look at the E2. E2 is the estrogen or estradiol. And E2 is what? Estrogen or estradiol, which is the active form of estrogen. So the estrogen is low. Now let's look at it very well. Then look at this anti-mullerian. What's anti-mullerian? Anti-mullerian is a kind of hormone that is produced by the ovary. Yeah, they are produced by the ovary. So usually they show signs of normal ovary. So normal level of anti-mullerian is actually showing that the ovary is sufficient. But low level of anti-mullerian shows that the ovary is insufficient. So there is not enough follicles in the ovary. So it is the ovary produces anti-mullerian as an indication that folliculogenesis is actually taking place and the normal productive cycle is well in the ovary. So ovarian activities is normal. So of course testosterone is the main one. Alright. So tretinoin is a drug. Now, since this FSH is high and LH is high, E2 is low. From this axis, we can see that FSH and LH are produced in response to GnRH. So GnRH from the hypothalamus stimulates the pituitary, anterior pituitary to produce FSH and LH. So Now for FSH and LH, we expected to think that yes, the reason is because the GnRH is actually stimulating the anterior pituitary to produce the LH and FSH. So that's okay. Okay? So by implication, once GnRH is high, FSH and LH should be high. But in this case, we are not measuring GnRH. Okay? Because it's difficult to measure GnRH normally. So what we normally measure is FSH and LH. Okay. So what means that once FSH and LH is high, we know that GnRH is normal. But there is a way to distinguish between the two. So we want to know this. Now estrogen is low. Alright? The idea is that if FSH and LH is high, then by implication they should stimulate the ovary to produce enough estrogen. But in this case, the estrogen is low. So that means there is a blockage, there is an accumulation of FSH and LH because this ovary is not responding to them. So there is an abnormal response between FSH and ovary. FSH and LH and ovary, there is a disconnection in their communication that is resulting in the low estrogen level. So from here, you can now see that because of the low estrogen level that is being produced, there is no feedback inhibition again. Feedback inhibition is lost. The feedback inhibition is such that if estrogen level is producing high amount, it should go back to the anterior pituitary and to the hypothalamus and tell them to stop further production of GnRH and FSH. And by implication, this FSH and LH, their concentration will reduce and the estrogen will come down. But here, because estrogen is too low, there is no more feedback. There is no enough message going back to tell the GnRH and to stop further production of FSH and LH. So because of that, the GnRH keeps stimulating the anterior pituitary to continue to produce FSH. And in this case, you can see that that is the reason why FSH and LH is high. So in this case, what could you say is the problem here? FSH and LH is being produced enough because the anterior pituitary is okay, and the anterior pituitary is producing enough because the hypothalamus is actually stimulating them. But where the problem now lies in so this case of primary hypogonadism. Primary hypogonadism. Why do we say primary hypogonadism? If the cause is from the ovary, we call it primary hypogonadism. But if the cause for the low secretion or the abnormal secretion of the sex hormone is from the pituitary or the hypothalamus, you call it secondary hypogonadism. Okay? So, and hypogonadism is a major reason for amenorrhea. So now for us to know which type of hypogonadism, that is why we are looking at this result. So from here we have known that the hypogonadism is caused by the ovary. So in that case we are going to call it primary hypogonadism. Why? Because gonadism is caused by the ovary, not by the pituitary nor ovary. So let's know this ovary is the one that produces estrogen and progesterone. For it to be low, that means that we have established that. Now, what is anti-mullerian, like we said, if the anti-mullerian is used to confirm the problem here, anti-mullerian is supposed to be produced by the ovary. Okay? So that means for it to be low, it means that there is ovarian insufficiency. So the problem is from the ovary. Alright? Now, look at it. The testosterone is high. Why? There is low estrogen and there is low testosterone. Of course, we said that ovary also produces androgen, of which testosterone is one of the androgen. So for testosterone to be high here, why is it so? The reason is because before estrogen will be formed, there is an enzyme that will have to convert androgen into estrogen. So if you test for testosterone and you know that testosterone is high, it means that the problem is actually coming from the metabolism within the ovary. So that is why if they further prove that this hypogonadism here is from the ovary. Because for the ovary to be able to produce testosterone, okay, that means it is receiving enough stimulus from these ones. But this estrogen that is low means that the metabolism, the arrangement in the metabolism is within the ovary. Because it is within the ovary that testosterone is being converted to estrogen. So there is no accumulation of testosterone. So the problem is really a deficiency. Maybe it could be there is a deficiency here. There is an inhibition of an enzyme, and this kind of condition may be caused by perhaps there is a drug that the individual is taking, which is actually an aromatase inhibitor. So an aromatase inhibitor, when administered, can block the conversion of testosterone to estrogen. So estrogen level will be low, but testosterone level will be high. So that drug is attached, it is used in the treatment of breast cancer. Okay? It will be used in treatment of breast cancer because estrogen, high level of estrogen in cancer patients, in breast cancer patients, fuels the cancerous growth to make it to be more severe. So most of the time, the treatment for such disease, such cancer, is estrogen inhibitors, of which that estrogen inhibitor could be the one that is causing this testosterone to be high when estrogen is low. So if you, that is what you can look at. Then another cause for which estrogen can be low, one other thing that can cause estrogen to be low could be polycystic ovarian syndrome, PCOS. Because in polycystic ovarian syndrome, you see testosterone level is usually high and the estrogen is low. So in this case, you can see LH is high. So one of the hallmark of PCOS, polycystic LH is usually high. Although in some cases, they say the LH ratio will be higher than the FSH. So, but in most cases, you may see both of them high. But the hallmark is that LH is usually high in a polycystic ovarian syndrome case. But for you to establish complete that it's good, you need to do ultrasound of the ovary to see the cysts. But without ultrasound, you can now be suspecting that if there is no drug, an anti-estrogen drug or estrogen inhibitor drug, then you may begin to suspect that there could be a polycystic syndrome, which you may refer the patient for what? For ultrasound. Alright. So this is what happens. So what we have been able to establish here now is that when you see that FSH and LH is high, then and the estrogen is low, it's a clear case of primary hypogonadism. Let's look at the second patient. The second patient, the FSH is low, LH is low, E2 is low, and antimularian is low, testosterone is low. So it seems that the whole axis, starting from the bata, which is the hypothalamus, the problem is here. The whole thing seems to be going good. So if FSH and LH is low, it means that they are not receiving enough stimulus to produce. Or, yeah, it's that they are not receiving enough stimulus to produce it. You know? So is either the reason is because the hypothalamus is not producing enough GnRH, or that the hypothalamus is producing enough GnRH, but the anti-pituitary receptors are not receiving or are not sensitive to the GnRH. So they will not be able to produce FSH. So now in this case, now we cannot really know whether the problem is from the hypothalamus or pituitary, because what we only measure is FSH, of which we don't know whether could it be that the GnRH is producing enough, is enough, the hypothalamus is enough, but the pituitary is the one that is not responding to the GnRH, or could it be that the pituitary is okay, but the hypothalamus is not producing enough GnRH? So we need to establish whether this is a case of pituitary dysfunction or hypothalamic dysfunction. So but let's look at other results that are there. So you can see estrogen, of course, will be low. Once FSH is low, LH low, estrogen will definitely be low, except in a case where there is ovarian cancer. Okay, ovarian tumor that is not producing estrogen irrespective of FSH or LH. So in that case, you may see a case where the estrogen is high, whereas these two are low. So in that case, we are seeing that now this ovary is no longer under the control of FSH and LH. So something may have been instigating the high level of estrogen from the ovary, and that could be tumor. So in this case, you are going to see, in the case of ovarian tumor, one of the hallmark is high level of estrogen with corresponding level of FSH and LH. Okay, so but now we are looking at this case of hypogonadism where the patient came with amenorrhea, low level of estrogen, and then we see antimony is low, testosterone is low, so everything is low. But now for you to know that what is called, there's a drug called tritoreline. Tritoreline is an agonist of GnRH receptor. So tritoreline, so you can say tritoreline is an agonist of GnRH receptors. So an agonist is something that spurs or activates, okay? It supports. So the receptors of GnRH are present on the anterior pituitary. So when you say that something is an agonist, it means it is what we stimulate. They stimulate it. So tritoreline is one drug that stimulates the receptors of GnRH on the anterior pituitary, so that the anterior pituitary will now start producing FSH and LH. So if you administer this tritoreline and you notice that FSH and LH was now able to come up, it's no longer low, it's now up, that come up to normal and even increased beyond normal, then it means that the problem ab initio was that the pituitary was not receiving enough response naturally from the hypothalamus, which is the GnRH. So in this case, you will be able to establish that the pituitary is okay, it's normal, but the problem is from the hypothalamus. Okay, so in this case, we have a normal pituitary function, which has been established by the fact that tritoreline, being an agonist, was able to stimulate it to produce enough. So that means, since artificial, because it's more or less an artificial or exogenous GnRH, so that means the indigenous one is not enough to stimulate the pituitary, and that means it is the hypothalamus that is not producing enough. So you can point this as a hypothalamic dysfunction. So in this case, the hypothalamus is the particular gland that is not really, that is dysfunctional here. And this can happen in the case of hypothalamus amenorrhea. When the hypothalamus is the cause of the amenorrhea, you can call it hypothalamic amenorrhea, secondary to hypothalamic dysfunction. So in some cases they say functional hypothalamic amenorrhea, that is FHA, functional hypothalamic amenorrhea, secondary to hypothalamic insufficiency or hypothalamic dysfunction. So this kind of amenorrhea resulting from hypothalamic dysfunction can actually arise. It can actually be congenital. That is in the case where it can be congenital if the person has never had menses before. So in that case, you say it's congenital from birth. That is where the disorder starts. But in the case of this patient, this person used to have menstruation before, but now it has stopped. So maybe the hypothalamus is okay, just that his ability to secrete GnRH has been impaired. So in that case, you now need to look at stuff that will stop the hypothalamus from releasing GnRH. Okay? So example of such condition is physical stress. Physical stress such as strenuous exercise, especially ladies that are into athletics. So you see those people, because of the level of stress or strenuous exercise that they engage in, their hypothalamus senses stress, and once the hypothalamus sense stress, one of the things it does is that it will shut down production of hormones, because if you go into survival mode because of the excess stress. So because of it, you affect most of the hormone that is secreting, this secretory activity. So one of the cause for which this we are going to get the history of the person. Are you an athlete? Another one is starvation. And starvation can cause this hypothalamus to sense stress, and then cannot produce enough GnRH. And that will now affect other hormones on the pathway and result in the amenorrhea that the person is. Emotional stress and anxiety. Of course, emotional stress. In fact, this is one of the, when we have checked other factors and we notice that the problem from the hypothalamus, alright, if we see that we gave this tutorial and the person was able to produce enough FSH and LH, and by implication was able to get enough, the estrogen was able to come up after giving the FSH. So you cannot say that here you can put that E2 was able to come up to. See? So in that case, you will say, you see mostly married people that have marital crisis. Most women that used to come down with secondary amenorrhea, that is amenorrhea that just started happening after some time. It may be as a result of emotional crisis or challenges that they are passing in their marriage. So it's affecting them psychologically, and that is why the GnRH is affected. Another one is that maybe, just like, okay, that takes us back to the first patient. In this patient now, because when somebody is approaching menopause, there is likelihood that there will be reduced number of oocytes or follicles. So because of it now, because there is no enough follicles, so even though this FSH and LH are all there, but since there is not enough oocytes anymore, the estrogen level will be low, because it is when there is enough oocyte that there will be folliculogenesis. So if the follicle is low, definitely then the E2 will be low. So and the person will experience amenorrhea. So maybe the eggs are not getting atrophied because the individual is approaching menopause. Because as one continues to ovulate, the number of the ovum or oocytes will be reducing. Okay? So the other causes of this may be drugs. There may be a drug that the person is taking that is affecting the hypothalamus. It's affecting the hypothalamus from producing GnRH. They are GnRH inhibitors. There are certain drugs that are GnRH inhibitors that affect the release of GnRH. So that could be the cause here. So if the person withdraws the drug, everything comes back. Maybe there could be another thing that causes this. Maybe there was a brain tumor. Maybe there was a brain tumor that is affecting the hypothalamus. Cannot produce enough GnRH anymore. Okay? Or maybe accidents that affected the brain, the hypothalamus. Okay? But in these cases, the result in patient 3 and patient 2 is similar. They are the same secondary hypogonadism. Secondary, both of them. But this one here, at this point, the pituitary did not have any effects. So the gonadotropin releasing hormone analog or the GnRH receptor agonist here didn't have any effects. So what do you think? If you gave this and didn't have any effect, that means that the problem is from the anterior pituitary. The anterior pituitary is stated that these receptors are lacking or they have been inhibited, so that even though you give the GnRH, the exogenous GnRH, it will not have any effects. And so FSH remains low. So possibly what could result in this may be that there is a GnRH receptor inhibitor or antagonist which the person takes, maybe as a result of another disease that they are treating. So the person is not taking that drug and the drug is inhibiting the GnRH receptors. So in that case, the pituitary anterior is not producing enough FSH and LH. So you can see this case now. You see that the cause of the secondary amenorrhea or the cause of the amenorrhea is secondary to pituitary dysfunction. And one of the things again could be there may be prolactinemia, because prolactin, if you measure, they may need to measure prolactin level as one of the tests, because prolactin has a way of it has a negative feedback on the anterior pituitary, so it can block the anterior pituitary receptors from accepting GnRH, so it cannot produce FSH and LH. So in this case, you may also do prolactin level. Okay. So and they know there are some drugs that is used in treating breast cancer that are meant to inhibit prolactin. Okay. So those they are actually meant to inhibit production of those drugs are meant to inhibit production of estrogen. So, and that prolactin is an antagonist of this GnRH receptor. So in that case, when somebody is on that drug for the treatment of breast cancer, it will affect the anterior pituitary ability to produce FSH and LH. Having said this, you can now see how we can diagnose problem of this particular case. So in case you see this kind of thing exactly, you should be able to explain from the results using this axis. So using this axis, you use it to explain it.